I think we can start slowly with our session about the hypothalamic-pituitary and growth disorders in survivors of childhood cancer, the Endocrine Society Clinical Practice Guideline. And I'm so happy you're attending us. So the guideline has been written by the committee, and the members were Dr. Sklar, Dr. Antal, Dr. Chambatili, Dr. Cohen, Dr. Fallin, Dr. Meacham, and Dr. Murad. And I will introduce us to you. My name is Hanneke van Zanten. I'm a pediatric endocrinologist in Utrecht in the Wilhelmina Children's Hospital, and I'm very honored to be able to moderate this session. And so the panel on my left side, on the left is Dr. Sklar, attending pediatrician and director of the long-term follow-up program in the Memorial Sloan Kettering Center in New York. Then Dr. Zoltan Antal, Chief Division of Pediatric Endocrinology at the Well Cornell Medical College and Memorial Sloan Kettering Cancer Center, New York. Dr. Laurie Cohen, she's the director of the neuroendocrinology program in the Boston Children's Hospital and also consulting staff of the Dana-Farber Cancer Institute. And lastly, Dr. Wasim Chemaitili, director of the Division of Endocrinology in St. Jude's Cancer Research Hospital in Memphis. So these are our disclosures. Now, the guideline has been published in the JCEM in 2018, and also you can find all information on the guideline resource page of Endocrine Society, and this includes links to the full published guideline, the online patient resources, the clinician education, there's a podcast, also an interview with the guideline writing committee chair, and there's also a point of care tool available in the app. So today, first Dr. Sklar will give you an overview of the childhood cancer survivorship. Then I will give you a short overview of hypothalamic-pituitary and growth disorders in survivors of childhood cancer. And then we have 3 cases to discuss with you, in which we will highlight the challenges we have in taking care of these survivors and the differences between the childhood cancer survivors and the other children with regards to hypothalamic-pituitary dysfunction. And I just wanted to ask you, you can submit questions anytime during our presentation, also through the app. And also the questions from the cases will be presented to you. You can find it also on the app, and you probably know, as this is the last day of the Endocrine Society, you know how to find it for the poll. So I'd like to introduce Dr. Sklar to give you an overview of cancer survivorship.
Good morning. I want to thank the organizing committee for giving us this opportunity to present to you in some detail our guidelines for the management of growth disorders and hypothalamic-pituitary dysfunction in survivors of childhood cancer. I'm going to give a very brief overview of cancer survivorship issues for those of you who are not familiar. And then Hanneke will really take you through the endocrine aspects and the specifics of the guidelines. So cancers in children are quite rare and actually account for less than 1% of the total cancer burden in the population at large. The cancers that we see in children and adolescents are very different from the common cancers that one sees in adulthood. Acute leukemia, especially acute lymphoblastic leukemia, is the single most common type of cancer we see in childhood, followed by tumors of the central nervous system, which are the most common solid tumors, lymphomas, which include both Hodgkin's and non-Hodgkin's lymphoma, and sarcomas of muscle, bone, and soft tissue account for another third. Wilms tumor, neuroblastoma, are renal tumors that are relatively rare, and then there are a whole host of very unusual, miscellaneous, and rare disorders that account for about 20% of all childhood cancers. So although cancers in children are relatively uncommon, fortunately, survival rates, particularly over the last 30 years, have made remarkable improvements. So on this slide, if you compare 5-year survival rates for children treated in the 70s, that's the yellow, compared to children treated in the most recent era for which we have data up till 2009, you can see that the overall survival rate for all types combined is approximately 80%, which is really remarkable. For the most common childhood cancer, acute lymphoblastic leukemia, current survival rates are between 85 and approaching 90%. Survival rates for Hodgkin's lymphoma actually exceed 95% for children and adolescents. These are all really startling and remarkable results. Now, because of the context of what we're going to be discussing today, many of the issues that we're going to be discussing have to do with children with malignancies of the central nervous system. And while there has clearly been improvement in 5-year survival rates in this population, unfortunately, they don't do as well overall as some of the liquid tumors that we've discussed earlier. So if you combine these remarkable survival rates with the number of children diagnosed yearly, which is approximately 13,500 in the United States, currently there are approximately 400,000 survivors of childhood cancer living in the country, and that accounts for 1 out of every 750 individuals. So those of you who take care of adults are very likely to encounter childhood cancer survivors at some point in your practice because of the ever-increasing number in the population. And actually, it's estimated by 2020, which is actually only next year, there'll be 500,000 survivors of childhood cancer living in the United States. So despite the tremendous improvements, or because of the tremendous improvements, we do have to recognize that cure comes at a price. And this slide illustrates a variety of health-related and quality of life adverse outcomes that unfortunately can occur in survivors of childhood cancer. Now, today we're really just going to focus on 2 areas, which is really the areas of growth and development and endocrine organ dysfunction. As you'll hear later, endocrine dysfunction is among, if not the most prevalent organ system dysfunction that we see in survivors of childhood cancer. But there are many other issues, including fertility and reproductive issues, second malignancies, and psychosocial issues, which we won't obviously be able to touch on. But it is important to understand that survivors of childhood cancer often have complex psychosocial and medical comorbidities that need to be taken into account during the management of their endocrine and growth issues. So what are the overall risk factors for developing these late complications? For the most part, and for most organ systems, we're really talking about the therapeutic exposures. So we're talking about chemotherapy, radiation therapy, and to some degree surgery. Because we are talking about, in this session, a lot of children with central nervous system tumors, I've added this balloon, which is not a therapeutic intervention, but the location of the original tumor can in fact have enormous implications for particularly late endocrine complications, as you'll see later on. I do want to reiterate, and I know that Hanneke will discuss it in some detail, but in the context of endocrine abnormalities, particularly neuroendocrine abnormalities, exposure to radiation and tumor location are the 2 key risk factors that we're talking about.
Welcome, everyone.
And it's very important to understand that radiation-induced abnormalities are both dose and time dependent. And that means that the higher the dose, the greater the likelihood for most outcomes, and the longer the interval after exposure to radiation, the greater the risk. So the risk for most of these problems tend to increase over time. And finally, these therapeutic exposures are also modified by a host of other factors, including age, gender, underlying genetics, lifestyle choices, exercising, smoking, and other medical comorbidities. So I'm going to now hand this back to Hanneke, who will give you an overview of the guidelines themselves.
Thank you so much. So with about 500,000 childhood cancer survivors living in the United States in 2020, we have to be aware of the possible endocrine-related effects. And it has been described that about 60% of all childhood cancer survivors will have an endocrine disorder, making this relevant for us as endocrinologists. So what are these problems? So today we will focus on the hypothalamic-pituitary endocrinopathies, but also due to hypothalamic damage and steroid treatment, obesity is seen in an increased prevalence, diabetes type 2 and metabolic syndrome. After radiation on the neck, survivors can develop hypothyroidism, hyperthyroidism, but also thyroid nodules and thyroid cancer is increased. After irradiation on the abdomen or again steroid treatment or other chemotherapy, diabetes type 1 has been shown to be increased in survivors, also insulin resistance or insulin insufficiency. After treatment with alkylating agents or abdominal irradiation or flank irradiation, also gonadal insufficiency has been described, with the males having azoospermia or Leydig cell failure, and the women having premature ovarian insufficiency. Also osteoporosis, osteonecrosis leading to frailty has been described. So many aspects that we have to be aware of. So specific for short stature and hypothalamic-pituitary dysfunction, there's been risk factors identified, and as Dr. Sklar also mentioned, there are certain host factors which can aggravate or increase this risk. So for instance, one of the risk factors is spinal irradiation, glucocorticoids, tyrosine kinase inhibitors, and retinoic acid. Those are risk factors to develop a short adult height or impaired linear growth. If you then also were younger at time of treatment, or if you had precocious puberty, the risk for small stature will increase. Same goes for hypothalamic-pituitary radiotherapy dose. The higher the dose, the higher the risk for hypothalamic-pituitary damage. For instance, if you've been treated with more than 30 grays on the head, you're at risk for central precocious puberty, and you're also at risk for growth hormone deficiency and deficiencies of the other axis. Again, if you were younger at time of treatment, or if you were have a female sex, or increased BMI, your risk increases. Same goes for tumor growth near the hypothalamic-pituitary region or surgery in this region. This will lead to a risk for panhypopituitarism, so growth hormone deficiency, LH, FSH deficiency, TSH deficiency, ACTH deficiency, and this risk is increased if the follow-up time is longer. So the key points of our recommendation are that hypothalamic-pituitary dysfunction is frequently observed in children surviving cancer or adults surviving childhood cancer. There's a high risk for patients surviving tumors involving the hypothalamic-pituitary region or after CNS radiation. Dysfunction after radiotherapy is dose and time dependent. If you've been irradiated on the head with a dose below 30 gray, the risk is primarily there for growth hormone deficiency and central precocious puberty. If you've been irradiated on the head with doses larger than 30 grays, you're still at risk for growth hormone deficiency, but also for LH and FSH deficiency, TSH deficiency, and ACTH deficiency. And this may occur years after completion of cancer therapy, and we will illustrate this in one of the cases. Risk factors for impaired linear growth and short stature are mainly radiation at young age, radiation to the CNS, TBI, and spinal irradiation. And the guideline emphasizes key differences and the unique features that are specific to the cancer survivors, and we hope to illustrate that today in the cases. So we will now go to the cases. So on your app, you can participate in the polls. I think you all know how to find it. And to test this, we will go to the first question. Who do you feel should do the screening for endocrine dysfunction in children or adults surviving childhood cancer? Should this A, be the pediatric oncologist? Should this be the general practitioner? Should this be the pediatric or adult endocrinologist? Should this be a trained nurse? Or should this be a late effects clinician? So you can start answering. Okay, so we feel that the endocrinologist should be the one who is doing the screening. I would like to ask the panel, Dr. Chamaitali, would you like to comment?
So I think that this was more for us to get an idea of what the perception of this problem of screening is for the audience. But in reality, these patients are involved in the medical system very early on and are treated by a variety of providers. So the responsibility for screening for not only endocrine-related effects but all related effects really depends first on where they are in their trajectory, who is the caregiver who's most frequently seeing them, and also on what the particularities of the institution, the practice in the institution in which they are followed. In some institutions, the responsibility of screening for all late effects is with the oncologist. In others, it's part of specialized clinics, staffed by family physicians. So it really varies. And I think the key factor, the key thing that we wanted to bring up is it's the shared responsibility. However, and I think this is where the response came from the audience, is we do have, as pediatric endocrinologists, a duty of education within our institutions because we're often at the receiving end of patients with these complications, sometimes at a very advanced stage. Sometimes we wish that we had seen these patients earlier. So there's definitely a duty of education that we have to provide to our colleagues, but also look in our institutions and see whether there's a system for these individuals and whether we have things in place to prevent complications from being non-treated for a long time.
Okay, thank you. That's good.
No, I just wanted to add that it's interesting. I work in a world as an endocrinologist with a lot of oncologists, and I speak to both endocrine audiences and oncology audiences. And the oncologists complain that they can't get their patients in to the local pediatric endocrinologist because they're too busy and they don't have an identified endocrine issue. And the pediatric endocrinologists complain that by the time they see the survivors, it's too late to do things. Things have been missed for a long time. So I think it's a contentious, complicated, and difficult situation. But if you truly believe that pediatric endocrinologists need to screen these patients, that means that you have to have the manpower and the commitment to see patients who have no identified problems but are simply at risk based on their previous exposure. And like Wasim said, that takes communication between two services. But I think it is an ongoing and difficult problem, and it's different at each institution. But I do think it's worth people thinking about how to best coordinate care for these kids at your particular institution.
Yes, thank you. So our first case. So we are presenting an 8-year-old girl, and she has had a metastatic posterior fossa medulloblastoma, and she was diagnosed at age 5. She had metastasis to the thoracic and lumbar spine. She's been treated with surgery with total resection of the posterior fossa mass. She's had a surgical resection of the spinal metastatic lesions. She has had chemotherapy with cisplatin, cyclophosphamide, and vincristine with stem cell rescue. Her treatment continued with radiotherapy, 36 Gray, craniospinal with boost to the posterior fossa of a total of 54 Gray, and the spinal lesions, thoracal 6 to lumbal 2, with a total of 50 Gray. She's had quite some toxicity. She's had a meningitis. She has had encephalopathy and seizures during treatment. She was in complete remission at age 5 years and 9 months, and now she's 8 years old. So we just wanted to be informed how this is for you in daily practice. Do you, in your own institution, do you have access to detailed information about the oncologic diagnosis and treatment at referral? So this for you is this: do you have access to limited information about diagnosis and treatment? Do you have detailed information about diagnosis and chemotherapy, but you have no access to organ-specific radiation doses? Do you have detailed information on all aspects of care, including diagnosis, chemotherapy doses, radiation fields, and dose exposures? Or do you have no information at all? Okay, that's great. So, Dr. Sklar, could I ask you to comment on what specific information is needed by the treating endocrinologist when a childhood cancer survivor is referred to the endocrine clinic? Dr. Sklar?
So the reason we're asking this question is that our guidelines are written with the understanding or the assumption that you do have access to detailed information because the risk for different problems is often very dependent on knowing what dose, particularly the radiation dose, to key endocrine organs are. And I know it's a huge problem. I know many institutions, despite great efforts on the specialist's part, it's sometimes very difficult to obtain the information that's necessary. I think, again, it's something that you have to work with within your institution. But if you don't have detailed information, you're basically forced to do screening that must assume that the patients have gotten the most significant or intensive therapy they could get under those circumstances in order not to miss important outcomes. So, for instance, if you don't know the hypothalamic-pituitary dose, but you know that the eye or the ear or the nasopharynx got 36 gray, and it's possible that the hypothalamus got the full 36 gray, then you are committed to doing an evaluation making that assumption. So the more information you have, the better you are. It enables you to be specific in the testing you do and to anticipate problems based on those exposures. So could you go back to actually what the responses were? Because it went by so fast I didn't actually, the percentages, do we have it?
No, I think they're gone.
Yeah.
Yeah. But
So-
most answered C.
Okay. So, but many of you don't have access to the kind of detailed information you would need to actually follow these guidelines. And I would just again urge you to appreciate that that kind of detailed information is really essential to provide optimal care to your patients and to insist to the best of your ability to get that information from the referring oncologist.
Thank you so much.
Can I
Of course, yes.
add one thing? Often the oncologists actually don't know about that information, and you have to go to the radiation oncologist directly, or ask your oncologist to talk to the radiation oncologist. But this is not something they necessarily think about either, how much radiation hypothalamus and pituitary receive.
Thank you. So the reason for referral to your endocrine clinic for this girl, now 8 years old, is short stature. And here you can see her growth chart, and actually you see a growth arrest. And the next question is, which of the following are the best next steps to further investigate the reason for this patient's poor growth? Would you do thyroid function test? Would you do growth hormone stimulation test? Would you do IGF-1? Would you do a bone age? Would you do a sitting height? Would you do A and B, thyroid and growth hormone stimulation test? Or would you do A, B, D, and E, that is thyroid function test, growth hormone stimulation test, bone age, and a sitting height? All right, great. Good. So, Dr. Antal, would you like to comment on this case?
Sure. So we set up this question and this case because we felt that the points on the guidelines were well addressed and highlighted in all of the exposures in this case. So beginning with the fact that she was very young when she was treated and her female gender certainly puts her at risk. Then there are a number of factors, including the fact that she received cranial radiation at 3600 gray. Again, we didn't specify the hypothalamic-pituitary dose, but assuming that she received a dose greater than, as we say in the guidelines, 18 gray, and here likely greater than 30 gray, she's at risk for multiple pituitary deficiencies. And then in addition to that, she was exposed to spinal radiation, here both as part of the craniospinal radiation and then again directly for the tumor treatment. So she was exposed to high doses of spinal radiation. And among all of the reports, this is one of the most significant limiting factors for short adult height in these survivors, and one of the things that's very difficult to overcome in terms of treatments. So basically the case highlights all of these exposures. And in addition to that, she had some medical comorbidities, and although not addressed in this case, we do talk in the guidelines about other things such as chronic steroid use, poor appetite, and other medications which may affect growth potential.
So thanks. And I have received an audience question. So is there a radiation dose threshold above which risk of endocrinopathy escalates significantly? Maybe it's nice to answer that. Oh, sorry.
Yeah.
Is there a radiation dose threshold above which risk of endocrinopathy escalates significantly? I think we mentioned it in the introduction, but it's an audience question that popped up.
I'm having trouble hearing. For what?
For any
Oh,
endocrinopathy,
okay.
yeah.
So as we say in the guidelines, in general, patients who get less than 18 gray as standard fractionated radiation are not felt to be at significant risk for neuroendocrine abnormalities. There is one exception, which may not be relevant to many of you, but for patients that get total body radiation as preparation for bone marrow transplant, that radiation is given in a different way, usually 2 to 3 doses per day over a very short period of time. So doses as low as 12 to 15 gray given as total body radiation also put patients at risk for at least growth hormone deficiency. But for patients that get standard fractionated radiation, as most of the brain tumor patients do and some of the leukemia patients do for prophylaxis, we generally think that 18 gray is kind of the threshold that puts you at risk. These patients need to be looked at and followed, and I think if you see somebody who got 16 or 15 gray and is growing poorly and there's no good explanation, then you need to pursue that. But in general, as a rule, it's very uncommon at doses less than 18 gray.
Thank you so much. I see more questions coming in about why not using IGF-1. We will address that question in a later slide. So the lab test returned, and the girl has a mild primary hypothyroidism with a TSH of 15 milliunits per liter and a low free T4, and she has a growth hormone deficiency. So because she's been irradiated to the hypothalamic-pituitary axis with more than 30 gray, there is a chance for central hypocortisolism. So the adrenal axis is evaluated before thyroxine treatment is started. And a low-dose ACTH test is done, showing indeed an ACTH deficiency with insufficient cortisol response. So hydrocortisone is started, levothyroxine for thyroid is started. And now the question of the parents is, you advise growth hormone, but should we really do this? Should we start growth hormone? So this is a question. What would you counsel the parents and the patient? Is it safe to start growth hormone after treatment for medulloblastoma? So A, no, growth hormone should not be given in this child. Yes, it's safe, but growth hormone should be started more than 1 year after achieving complete remission. Yes, growth hormone can be started as soon as growth hormone deficiency has been diagnosed. Or yes, growth hormone is safe, but we have to administer it at a lower dose. All right, that's excellent. So, Dr. Cohen, would you like to comment?
Okay, I'm glad to see that answer. So people worry about growth hormone being not safe in cancer survivors because growth hormone and IGF-1 have mitogenic properties. But there's actually no evidence that growth hormone causes recurrences. You do have to counsel patients and families because if a patient does have a recurrence, clearly there's a lot of guilt that gets involved, and you have to really make sure that they understand that this is not their fault for this happening. The question has been also about second neoplasms. And to date, the evidence does not show that there's an increase in second neoplasms. There was thought to be an increase in specifically meningiomas and gliomas. But after radiation, there's an increased incidence of meningioma, gliomas, and the latest data do not support that either. As for waiting for a year, that's somewhat arbitrary. It's not like there's a magic number that at 365 days you're suddenly fine to receive growth hormone. But most recurrence is going to occur during the first year. You certainly don't want to be treating somebody who's sick. It also allows time for recovery because, as you know, many patients who have been treated for cancer may be undernourished or have resistant states due to inflammation. So 1 year has been set at the time, but there's nothing magic to 365 days exactly.
Okay, thank you. Dr. Sklar?
Just to speak to the point of the year, part of the reason that that recommendation is in place is that they're really if you look at all the studies that have looked at growth hormone safety in terms of recurrence and second malignancy, the vast majority of those studies have actually included primarily patients who were at least 2 years off treatment. But there are a few smaller studies that have looked at patients as early as 1 year and didn't find an effect. But we actually don't have data, which doesn't, of course, mean that it's a risk, but we don't actually have published data to support the safety of using growth hormone at a point earlier than a year. So, for whatever reason, that's the design of most studies. So that's really the primary reason for the recommendations.
Yes, thank you. So these are recommendations for growth hormone deficiency. Now, suppose somebody has Turner syndrome and the medulloblastima, and is not growth hormone deficient, but would be eligible for growth hormone because of her Turner syndrome. What would we recommend then?
So our recommendation, there are actually no data whatsoever. Recommendations are to be careful with growth hormone and to reserve it for patients who are growth hormone deficient. But we really can't come out and say for certain whether that would be bad or not to treat with growth hormone.
Thank you. And so I see on the app there's another question, and maybe Dr. Antal, you would like to answer it. So the recommended diagnostic test for central hypocortisolism in these patients, we said an ACTH test was used. Do we recommend a low-dose ACTH test or a high-dose ACTH test for the diagnosis of central hypocortisolism?
We refuse to answer that question on the grounds that it may.
I'm sorry, I'm just a messenger.
Thank you for choosing me to answer that question. So I think in terms of testing for cortisol deficiency, one of the things we highlight in the guidelines is that we should have high clinical suspicion for anyone who's been exposed to treatments greater than 30 gray. But we don't think that cancer survivors necessarily need different guidelines than non-cancer survivors. There is certainly an abundance of literature that argues about whether 1 microgram or 250 low dose or high dose ACTH stimulation test is most appropriate. And then also clinically, we discussed the concerns about being able to administer 1 microgram accurately. And so, I would go and say, outside of the guidelines, just from a clinical practice standpoint, that we probably do both at our institution. We tend to do mainly standard dose ACTH stimulation testing at Memorial, but certainly we recognize that both are done.
Yeah, so in fact the recommendation is not different than other children who you suspect for central hypocortisolism.
Excuse me, but if you assess growth hormone deficiency in this patient, you have probably done a glucagon test or something like that. So you may have the cortisol answer without doing any ACTH test, high or low. So I think, and I think in the literature you have more data on the assessment of cortisol response with glucagon tests of ITT than with a low or high dose ACTH test. So I don't think there's any discussion about that.
Yes, thank you very much for that comment. You can take the cortisols with you when you're evaluating the growth hormone axis. I agree.
There are many ways to diagnose it, and it may not be practical, for example, to do a stimulation test every year, and so there can be recommendations about doing morning cortisol levels as well. But again, you have to look at what your practice is and what you agree with, because there's going to be no consensus as to how to diagnose.
Yeah, it's hard here. Yeah.
Sorry, can you hear me now? Okay. So I was just saying that you have to look and see what your own practice is, that just like Everything else, we're recommending the same kinds of tests that you would do in your own practice. And as you know, it's very controversial as to how to screen. It may not be practical to do ACTH stimulation tests, for example, every year, and there is a role for morning cortisol levels as well. But we can't recommend any one test for all the problems that there are with the diagnosis.
Right. I just want to emphasize the fact that there is no data to support that the diagnosis of ACT, that the tests required to make the diagnosis of ACTH deficiency in cancer survivors is any different than it is in the general population. And so there are many options. Some people use glucagon, as you said, because it provides you both with cortisol levels and growth hormone, but many centers don't use that. But there's no reason not to use it in cancer survivors if it's something that you use standardly when you're evaluating your other patients for short stature. So I think our point is not that you need to do a specific test, but rather that the testing you do should be similar. We do discuss ACTH stimulation testing because there is an Endocrine Society guideline for the management and diagnosis of hypothalamic-pituitary disease, primarily in adults. That was published about a year and a half ago. And in that guideline, they specifically recommend the standard dose ACTH stimulation test based on a meta-analysis that was performed as a companion study to that Endocrine Society practice guideline. So, but as in terms of cancer survivors, we're not making any specific recommendations.
Thank you. So there's one more question, then we're going on about the safety of growth hormone. If their child or young adult has an active craniopharyngioma and it's been a year, is it safe to start growth hormone?
Craniopharyngiomas are considered to be a benign cancer that cause a lot of morbidity. Patients with craniopharyngiomas can be treated with growth hormone. Many of them actually do continue to have craniopharyngioma tissue. It's rare that you do have a complete resection and that it's all out. So the recommendations are you can treat a patient in certain circumstances with stable disease. But again, you want stable disease, and that is true for optic gliomas as well.
Okay, so we're going on. So she's been on growth hormone, and it's now a year and a half later, and she's had growth hormone treatment with 0.2 milligrams per kilograms per week. She still has a frail appearance with pallor and alopecia. She's wearing hearing aids, and she's independent for most daily life tasks. She's going to second grade, and she's doing fairly well. So on examination, you see the surgical scars on the back of the head and along the spine, and she does have a decreased spinal mobility. Tenor staging is 1 for breast development and pubic hair. And this is her growth chart, so that's really disappointing, of course. And the lab test results show you a free T4, which is normal, a TSH, which is somewhat lower, an IGF-1, which is in the normal range, and her skeletal maturation is consistent with a bone age of 6 years at age 8, so it's a little bit behind. So, what should we do? She's not growing on her growth hormone treatment. Should we reduce thyroxine supplementation because TSH was lower? Should we increase the growth hormone dose? Should we add sex steroids? Should we measure sitting height? Should we do a karyotype analysis? Or should we screen for celiac disease? Okay, so we have to measure sitting height. Thank you so much. Who of the panel would like to comment? Dr. Sklar, perhaps?
Sure. I'm very impressed. You guys know a great deal. I'm not sure you need us. But yet I think that the point of the question is that there are obviously many different things that one could think of And we're not saying that if you clinically suspect that this patient has celiac disease or this patient has stigmata of Turner's, despite the fact that she has a medulloblastoma, that you shouldn't order those tests. But the likelihood that any of those other things are relevant is very, very low. Two things to mention. The TSH had been 15, and now it's 0.1 with a high normal free T4. So maybe that reflects the fact that she's on too much thyroid medication. But it's also possible, although it's a short interval, that she's developed central hypothyroidism, that she's become TSH deficient. And the reason that her TSH is now low is not because she's on too much thyroid medication, but because she's no longer able to mount a TSH response. The only way that you could figure that out would be to reduce her dose of thyroxine and see if the TSH comes back up. But these patients that get craniospinal radiation are at risk for primary hypothyroidism most commonly, but they can develop central and they can develop a mixed picture. So that's something to keep in mind. And I think it wouldn't be unreasonable to titrate her dose of thyroid medication down a bit to see, but that would be an extremely unlikely explanation for poor linear growth. And I think, unfortunately, the most likely explanation is that she's had a ton of spinal radiation at a very young age. And this next slide, which is really from Jeff Silber from the University of Pennsylvania, this is a mathematical model based on how much height one would expect a patient would lose following a relatively small radiation field to part of the spine. This is a Wilms tumor field. So it only includes basically the lumbar spine. But what you can see is that the younger you are and the higher the dose of radiation, the greater the height loss. If you get your entire spine radiated, as this child did, and you get a boost to certain areas, and she was quite young when this happened, one would anticipate an extremely poor response to growth hormone. And there's likely nothing that you can do that would make a clinical difference in her outcome. Now, her dose of growth hormone is on the lower side, even, and we published a study showing that in cancer survivors there is a dose-response relationship up to 0.3. Since her IGF-1 is in the mid-range of normal, I don't think it would be. I think it would be reasonable to increase her dose slightly, titrate it to the upper limit of the IGF-1, but I doubt very much that that would actually buy her much improved growth. So I think the thing is that you need to appreciate from the get-go that this child is an extremely poor candidate for growth hormone treatment. And I think one of the important things you can do is to counsel that family from the beginning, saying, she's growth hormone deficient, we'll give her growth hormone therapy, we think it's safe, but because of her previous exposure to such high doses of spinal radiation, we know that she's not going to respond to growth hormone like a normal individual, and likely will end up well below her genetic potential, despite any hormonal interventions that we attempt. So.
Thank you.
There's one thing I would like to add. In my experience with similar children, they can also have a poor response to growth hormone by the fact that they could have superimposed scoliosis and problems with the growth of the spine itself. In particular, in a child like this who's had interventions on her spine. These children can be very difficult to assess clinically. For example, the way we look for scoliosis, we ask them to bend down. If she has very decreased mobility in her spine, it's something that we may not be able to assess. So very important also to make sure that these children have proper orthopedic follow-up and evaluations, because it could be also multifactorial.
Thank you. And another question from the audience is, should we measure arm span?
Oh, I'm sorry. No, I just wanted to also, just as a final point, I think a lot of parents are very knowledgeable about bone ages, and they ask us about bone ages. And in this child, we had a delayed bone age here. So again, in doing the height predictions, we also counsel them that those are probably going to be very, very different from children who haven't had spinal radiation, because of course, once they're started on growth hormone, the questions are always the same. How tall will he or she be? How much time do we have left for growth? And a lot of that is very different from the non-childhood cancer survivor who hasn't had spinal radiation. So.
I think that's a really important point. I'm glad you raised it. Is that not only is it likely, a bone age will be completely unreliable under these circumstances, and one should not attempt to give one because you will grossly overestimate this child's final height, and it will only lead to expectations that are way out of line with reality. There is, to the best of my knowledge, there is no way that you can provide a reasonable estimate of final height, particularly in this age after these exposures. But I would absolutely refrain from making any attempt of making a height prediction based on bone age under these circumstances.
There was a question about arm span. So sitting height is the best way to measure upper to lower segments. It is not always practical for everybody. You can measure, I don't know, okay, you can measure lower segment, but again, sitting height is best. In terms of arm span, it's the least accurate. It can actually be helpful, however, to show parents how a child is growing, because if you can show them that their arm span is significantly longer than their height and that it's changing over time, they do see that the growth hormone is working. It's just not working in the way that you expect because the spine can't grow. So I wouldn't exclude arm span. I just would not solely rely on it.
Okay, thank you. So I'm not going to read these recommendations to you. You can find them in the published guidelines. But the take-home messages are that you should measure sitting height in children irradiated on the spine. Be aware of scoliosis developing during growth hormone treatment. Don't rely on bone age if the child has been spinally irradiated. And growth hormone is safe in child cancer survivors, and we only have data when it started over a year. So we go to case 2. So this is a boy who's 9 years of age. He's had a history of an optic pathway glioma at age 5. He's been treated with chemotherapy, vincristine, lomustine, thioguanine, and procarbazine, with a cyclophosphamide with an equivalent dose of 14.8 grams per square meter. He's not been irradiated, and he had the completion of therapy at age 6 years. So he's now 3 years beyond completion of therapy. And here you see his MRI scan with the glioma here. And now he's age 9, and he has his endocrine assessment. And it was already done at diagnosis, then it was negative. He's doing well, he's very active, he has some extra support in school, but he's had some pubic hair over the past several months, his mother tells you. So the physical examination shows you a height at the 47th percentile, a weight at the 78th percentile, BMI at the 85th percentile, and tenor stage 2 for pubic hair, tenor stage 2 to 3 for his genitalia, and testicle volume of 3 cc on both sides. So here you see his growth chart. So in the beginning, maybe he declined a little bit, but then he catched up and he has had a perhaps normal growth. And here you see it in more detail. So what's the correct next step? You have a boy of 9 years old, 3 years after completion of treatment for optic pathway glioma, now with some pubic hair. And testicular volume is 3 milliliters on both sides. Do you find A, testicular volume is very reassuring, pubic hair must be premature adrenarche, so no additional investigations necessary? Or B, height felicity is reassuring, no additional investigations necessary? Or C, testicular volume and growth rate are unreliable, and we should consider additional investigations? Okay, very well. So what is the best next step? Who would like to comment? Dr. Chemaitili?
Yes, I'm actually very excited about the response of the audience, and it probably shows that we have an overrepresentation of pediatric endocrinologists, because this is really one of the main traps in the follow-up of these patients. These patients can have superimposed, obviously, growth hormone deficiency and precocious puberty, with the superposition with stimulation from the sex steroids of skeletal growth, giving a somewhat misleading, a normal prepubertal growth rate, while in reality it is suboptimal given that puberty is underway. So definitely an evaluation of the puberty is warranted. Now, testicular volume is not a good way to measure or assess puberty in this population after exposure to gonotoxic treatments like for this kid, because as many of you know, Leydig cells are not as sensitive to cancer treatment as the germ cells, so we all see this dissociated phenotype with normal virilization and normal testosterone or elevated testosterone with small testes. So next step is to do a proper evaluation of puberty using a testosterone level, morning testosterone level drawn before 10 a.m., and also considering growth hormone testing to unmask this particular association.
Thank you so much. So that was done. So thyroid axis was checked, and the SPRT4 level was low normal with a normal TSH. Cortisol in the morning was normal, and the gonadal axis showed a testosterone of 191 nanograms per deciliter, which is high for a prepubertal male, of course. And his LH and FSH were detectable with an LH of 2.4 and an FSH of 10.4. And the bone age was performed, and this was accelerated with a bone age of 13 years at the age of 9.5 years. So what's your conclusion? Is the high testosterone and the accelerated bone age caused by premature agenically because the testis volume is 3 cc? Or is this high testosterone caused by central precocious puberty and the testicular volume is unreliable? Thank you. Very well. So the audience knows. Dr. Chemaitili? So would you comment again about the reliability of the testicular volume after gonadotrophic treatment?
So again, as I explained, and I'm sorry I gave it away, but it shows my
That's okay.
excitement about getting the proper response, because this is really one of the main things that we see in our practice of missed opportunity for managing these patients. So we cannot use testicular volume in this population. Again, this goes back to Dr. Starr's initial comment as to why it is so important to know the treatment exposures. You really need to know if this individual was exposed to gonotoxic chemotherapy, if there was exposure to testicular radiation, to know whether you could use or not testicular volume in the evaluation. And when in doubt, again, low threshold for ordering testosterone levels.
Yes, and so the very first question we asked, who should do the screening? So is this an argument when we talk about who should do the screening? Should we incorporate these kind of cases in these kind of recommendations?
Yeah, I mean, absolutely. I mean, I think these are the kinds of cases that we all see. Patients growing at the 50th percentile for 2 years, looking perfect to the oncologist, but being in puberty at age 6. Or the male with small testes and the nurse practitioner from the brain tumor service saying no signs of puberty when you ask. So these are the kinds of things that a trained specialist is likely to pick up that are frequently missed and overlooked when generalists or oncologists are following these patients. So I would certainly think that this is, the perfect example of why ideally we should be seeing these patients early on and screening them forward.
Thank you. And there's another audience question. Does halting central precocious puberty add any height in this group? What does the panel think? Treating central precocious puberty in this group for this boy, would that add anything to his adult height? Please talk very into the microphone.
Yeah, so there again are not a lot of data about treating to adult height, whether it makes a difference. we would use the same criteria that we would see in other populations, but expect that maybe we would do a little bit better because in this population, this is truly a pathologic process. So while we might not normally say that a girl, for example, who at age 8 would gain adult height, in this population, because she was not pre-programmed to genetically go through puberty at age 8, she might. But again, there are no good data to say one way or another.
I just wanted to add, in many of the cases, and like in this case here, the children, particularly if they have NF1 or some other associations with optic pathway tumors, when they come to us, if they haven't received radiation, then they're not at risk for growth hormone deficiency the same way as if they did receive it. So in those cases, we often see that treating them for precocious puberty at these younger ages does, decrease obviously the progression of bone age and probably does add some height. The exact amount is difficult to say because all of those children's heights may sometimes also be affected purely also by having NF1, for example. So I think it's challenging to tease all of those things apart. But I just wanted to make the point that if they're not specifically at risk for growth hormone deficiency because they haven't been radiated, it would be reasonable to treat them for precocious puberty as you would any other precocious child.
In this instance, we have a hypothalamic-pituitary mass. So this is somebody who's clearly at risk for growth hormone deficiency and central precocious puberty, as opposed to an NF1 patient with no tumor, which they're pretty rare. But this is clearly a case where there's an explanation, and one should anticipate both precocious puberty and growth hormone deficiency by the location of this tumor.
Yeah, so thank you. Oh, sorry.
I would just also add that there are other causes for precocious puberty in this population, so hydrocephalus, for example. So again, low thresholds for diagnosing organic precocious puberty as opposed to just sort of idiopathic.
Yes. So here you see again the growth chart. So with this testosterone, he should have had an increased growth rate, acceleration, and he didn't. And that is why he's suspect for growth hormone deficiency. So, and I saw some audience questions about this, because in the previous case we didn't recommend IGF-1, but maybe now we should. So what's your idea about the recommended diagnostic test for growth hormone in this child or in children surviving cancer? Should we do an IGF-1 and IGF-BP3? Should we do a growth hormone stimulation test? Should we do a spontaneous growth hormone secretion? Or do you, in fact, not really need any laboratory investigations because you have a growth rate which is not increasing while he's in puberty, so maybe that's enough in combination with tenor states, growth height, velocity, bone age, and also the findings you already had on MRI. Okay, thank you so much. Dr. Cohen, would you like to comment?
So you have a high pretest probability of growth hormone deficiency in this patient. This patient received more than 30 gray of cranial radiation. This is optic. No, I'm sorry. It's the tumor location. So you have high index of suspicion for growth hormone deficiency. In all of these cancer survivors, your best testing is growth hormone stimulation testing. The problem with using IGF-1, you can use IGF-1. It will certainly tell you who's profoundly growth hormone deficient. You should consider using IGF-1 if you've got multiple other pituitary hormone deficits, so somebody who's pan-hypo-pit. But there are many normal IGF-1 levels. This is very similar to non-brain tumor patients, that you can have normal IGF-1 levels. And in fact, there are studies that show in this population in particular that you can have normal IGF-1 levels. They're usually in the -1 to -2 range. If you did have an IGF-1 level that was above mean or median, it is much less likely that they have growth hormone deficiency. But we would recommend growth hormone stimulation testing in these cases to make this diagnosis where you have a high index of suspicion. As to the modality for that, right now our recommendations are based on other recommendations for the non-childhood cancer survivor, keeping in mind that growth hormone stimulation testing is not perfect, and the higher your cutoff, the more likely you are to diagnose growth hormone deficiency that doesn't exist. But again, growth hormone stimulation testing would be our test of preference.
I would like to add one more thought and building a little bit on Laurie's confusion in responding to this initially. There's really a widespread understanding of children treated with radiation as a primary population for hypothalamic pituitary dysfunctions, and the oncologists tend to be very good in referring patients systematically with such exposures. Oncologists may not think of these issues in individuals who were not radiated, and sometimes the onus is on us to have a continuous dialogue with the oncologist, or also to screen these patients if we're seeing them for some other reason. So very, very important not to restrict the screening for hypothalamic pituitary dysfunction only to those who are exposed to high dose radiation.
I'd also add from communication among this group that many of us, in particular with hypothalamic glioma, so you saw that large glioma in hypothalamic pituitary area, may have higher IGF-1 levels for unclear reasons, but clearly not be growing well. So in that population in particular, IGF-1 levels are not reliable.
Thank you so much. And maybe to add, there's a good remark from the audience. I see that hypothyroidism should be corrected before you do a growth hormone stimulation test. So that's good. Thank you so much for the remark. So additional endocrine investigations showing an IGF-1 minus 1 SD for age. And arginine and clonidine testing was done with a peak growth hormone of 5.3 nanograms per ml. And so in conclusion, this boy indeed had a growth hormone deficiency and central precocious puberty, and he was started on growth hormone daily with a GnRH agonist. So the guideline recommendations relevant to this question is not to rely solely on serum IGF-1 if you think of a growth hormone deficiency, because it can be normal in children with a growth hormone deficiency. And the same provocative testing is advised in children surviving cancer as children who didn't have a cancer history. And again, we recommend against using testicular volume as the primarily or sole indicator of the degree of sexual development in males, in the ones who have had previous treatment with gonadotoxic treatments. And in these cases, we recommend to measure a morning testosterone. And these recommendations, of course, can be found in the GCM publication. Any more comments?
So one of the questions that I've sort of sneaked looking at is what we do with does treatment with chemotherapy expose individuals to hypothalamic pituitary dysfunction? And I think that the evidence for chemotherapy causing hypothalamic pituitary dysfunction in general and growth hormone deficiency in particular has been not as compelling as for the other risk factors that we've discussed. However, the fact that data is lacking doesn't mean that the risk doesn't exist, in particular for a subset of therapies. So what I would say is if you see a child for whom you have clearly a clinical suspicion for growth failure due to growth hormone deficiency or any other hypothalamic pituitary dysfunction, it is okay to assess as you would assess any other child, but that this is an area of continued investigation.
And there's an additional question. So what's the latest bone age, boy versus girl, which you would recommend initiating GnRH therapy for CPP?
Again, the practice would be whatever your practice is. I don't know that there's a threshold bone age. If you make a diagnosis of precocious puberty, you need to make decisions as to whether or not GnRH agonist is beneficial both medically, height-wise, and psychosocially. And again, I think it would be exactly the same in this setting with cancer survivors as it would be for non-cancer survivors. I don't think we can give you at least I can't give you a threshold bone age. Obviously, if the patient's fused, then there would be no height benefit, but there might be psychosocial benefit from suppressing sex steroids at a young age. But again, it's the same as you would generally use for any of your patients with precocious puberty.
And another comment from the audience is that they agree with the advice for growth hormone stimulation test, but an irradiated hypothalamus could have a normal growth hormone stimulation test. So how do we deal with that?
Well, first of all, one of the things to keep in mind that we didn't discuss is you should not use growth hormone releasing hormone because the damage from radiation is felt, at least initially, to be primarily hypothalamic. It is possible that you could pass stimulation testing and still have growth hormone insufficiency. There has been a lot written about neurosecretory dysfunction, but unfortunately, using spontaneous overnight growth hormone secretion is not very reproducible or very practical for most people. As to the benefit for a growth hormone insufficiency as opposed to more of a deficiency and outcomes, that's also less clear. So for now, we are still stuck with growth hormone stimulation testing. But oftentimes with insufficiency, that will evolve over time. And so the important thing is that even if you have a patient who passes growth hormone stimulation testing, you're not done. You need to continue to follow them. And if you have a high index of suspicion, you may repeat that a year later or even sooner.
Yeah. And I would say that this phenomenon of neurosecretory dysfunction, probably if you trained within the last 20 years, you don't have any idea what I'm talking about. But if you trained before that, it was a big issue a long time ago. In my own clinical practice, which I have a very, very large cranially radiated population, it's extraordinarily rare to find a patient who's got clear-cut clinical growth hormone deficiency who actually passes growth hormone stimulation testing. So while it may occur, I think it's very, very infrequent. And again, if you're convinced that the patient's growth hormone deficient despite testing, then there are other things one could pursue. But I think it's a very, very infrequent problem.
I think you also need to keep in mind, especially in the adolescent years, that there are other reasons for a growth hormone insufficiency. So, for example, lack of sex steroids will cause a relative growth hormone insufficiency. So you do need to make sure that your hypogonadal patients are replaced adequately with their sex steroids. Well-meaning people will keep pushing up growth hormone doses when the children really need their sex steroids. Question, Nathan?
Yeah. Please go to the microphone. And while you're going to the microphone, another question was, if IGF-1 is not reliable as diagnostic test, is it reliable when you're giving growth hormone to monitor your treatment?
It's not that it's an unreliable test. It can be helpful, and it certainly can identify the patient with profound growth hormone deficiency. We do want to use IGF-1 as a guide. You don't want to give too much growth hormone to a patient. If a patient is growing well, the goal is an IGF-1 level that is around median or mean, but you certainly want to keep that level within normal range. If you look at the studies that show IGF-1 as not being reliable, again, most of those patients had levels that were -1 or below, and certainly below mean or median. So again, you can target a higher IGF-1 level.
Yes,
but
please.
as far as we know, on growth hormone therapy, IGF-1 levels do reflect the treatment you're giving, and we interpret them in the same way that we interpret them when we're giving growth hormone to patients who are not cancer survivors. So I think we all agree that it's an appropriate and useful thing to do in monitoring the dose of growth hormone.
And similarly, like the recommendations in the general population, IGF-BP3 does not add additional value.
Yes, please.
So my second question was, what is more common in post-cancer treatment? Is it hypogonadotropic hypogonadism or precocious puberty?
So the answer really depends on the age. You obviously cannot have precocious puberty after a certain chronological age. So among individuals for whom would qualify for that diagnosis, meaning before the age of 8 or 9 years, precocious puberty is among the most prevalent hypothalamic-pituitary dysfunction, right up there with growth hormone deficiency, especially in the context of patients with hypothalamic-pituitary tumors or tumors located near it. As far as hypogonadotropic hypogonadism, same thing. It's a diagnosis that cannot be made really until the age of, what's the latest for normal puberty, which is 13 and 14 years respectively in boys and girls. It is an entity that seems to be fairly frequent among adult survivors of childhood cancer with an increased risk along with time, as Dr. Sky had explained in relation to radiation. So really the answer is, well, it depends on the age. Both are fairly prevalent and probably more prevalent than what we think.
But I think also precocious puberty is a relatively early onset after radiation and acute onset after tumors. Gonadotropin deficiency, and I know it's the next case we're going to discuss it, so it usually takes years to develop after radiation. So it's not something you're likely to see in younger patients who, even if they get high dose cranial radiation, it tends not to evolve. It evolves over many years, 5, 10, 15 years. So we don't see it very often in the pediatric age.
Yeah, and considering time, I would like to go to the next case because this will be discussed in the next case. I see one more question. Is it a short question?
It's just a quick question,
Yes.
just to know if the panel uses which cutoff do you use to define GH deficiency in these patients, because it was 5.3. Someone would say it's not GH deficient, so I want to know
Yes.
which cutoff do you use for this kind of
I
patients.
think it's recommended to use the same cutoff as in
Yes.
non-cancer.
We're recommending the same cutoffs. However, the cutoff, I think there's a lot being written that the cutoff of 10 that's used in the United States is too high with the newer assays. If you really want to be suspicious of growth hormone deficiency, probably a cutoff of less than 5 to 7. But again, no great data, but yes.
Okay,
Be careful with the 10.
Thank you. So the last case is about transition. So now you're an adult endocrinologist, and you get referred a male, 28 years, and he's had a medulloblastoma when he was age 8. And it was a medulloblastoma with metastasis to C3 Toracal 11. And he's been treated with radiotherapy, proton radiotherapy, 36 gray, craniospinal, with a boost to the posterior fossa of 54 grays and to the spinal lesions. He's had chemotherapy by the protocol ACNS 0332 with vincristine, cyclophosphamide, carboplatin, and cisplatin. And he was in complete remission at 8-9. So it's almost 20 years later now. So he was known from age 9 at the pediatric endocrine department, and he had a central hypothyroidism for which he used levothyroxine. He had central hypocortisolism for which he used hydrocortisone. He had had a growth hormone deficiency, and he had been using growth hormone until the age of 16 with a final height of -1 SDS, but he had no hypogonadism. He had had a central precocious puberty, and he had been treated with GnRH analogs from age 9 to 11. So he was transferred to the adult endocrine department at age 18, and growth hormone treatment had been stopped upon achieving final adult height. And now he returns at your endocrine department with complaints of fatigue, and he's still taking his thyroxine and his hydrocortisone daily. So as an adult endocrinologist, which endocrine diagnostic test would you now do? Would you do a thyroid function test to check if his dose is adequate? Would you do an LH and an FSH and a morning testosterone? Would you do an IGF-1? Or would you do all of the above? Okay, great, thank you. So who would like to comment? Dr. Antal?
So, sorry, we wanted to discuss this case for a number of reasons. One is the question of transition, which comes up for a lot of things in pediatric endocrinology, but particularly among childhood cancer survivors. How do we graduate them and move them to adult care? And then secondly, of course, counseling them on the likelihood of ongoing diagnoses that have not yet been made in childhood but may develop over time, as was in this case. We didn't explicitly say that he wasn't followed for 10 years, but it's quite possible that he wasn't, and then comes in 10 years after he left pediatrics, 20 years after he completed his treatment, and has symptoms that may not have been diagnosed or were ongoing. So certainly, the key point to reiterate that I think others have said on the panel is that his risk continues and increases over time, particularly because he was exposed to the cranial radiation. And so here, although he wasn't diagnosed with hypogonadism prior to leaving the pediatric group, that certainly is a possibility. And the other is ongoing growth hormone deficiency despite stopping growth hormone because he completed his growth. And I think we have a slide here. So this is just a recent study, again, first authored by Dr. Shemateli. This is a report of childhood cancer survivors in the St. Jude lifetime cohort. And here you see the various anterior pituitary deficits, growth hormone deficiency, LH-FSH deficiency, TSH and ACTH deficiencies, and the cumulative incidence over time. And as you can see, the LH-FSH deficiency, so there in box C, which we are highlighting here, does continue to increase over time, particularly there 20, 30 years after diagnosis. And this cohort was followed for over 25 years and is one of the best examples of long-term follow-up representing the ongoing risk for developing pituitary deficits.
And thank you so much. And I see another question. As an adult endocrinologist with an interest in this area, what are suggestions on how to best connect with this patient population?
So I can say that in our institution, I'll speak about Cornell because I think at Memorial Sloan Kettering we have a system where we have an adult survivor pediatric group. At Cornell we didn't have connection specifically, but once we opened up the conversation with the adult endocrinologist, we realized that they were receiving quite a few of these survivors and were looking to connect with us as well. So first I think the key is communicating. And that, I think, will open up a significant discussion, an avenue of discussion for creating a program.
I think, like in many collaborative things, identifying a single interested person. You can train an adult endocrinologist to be to take care of your kids. You just need to find somebody who's open and willing. And I think that is really the key. I think if you try to send these kids to a division of adult endocrinology and whoever happens to be the first available is going to see them, it's not likely to be a successful transition. I think it really needs to be, a transition to an individual or team of individuals who identify themselves as being open and interested and committed, which is not so easy, but I think that's an essential step.
Keeping in mind that the transition of this patient population with chronic conditions is a little bit more difficult than just handing them off to the adult endocrinologist. They often need a little bit more hand-holding and a more formal transition program in place. So again, just increasing transition awareness in your institution for any of the patients with chronic conditions. One other point with this patient is just to keep in mind that you can have precocious puberty followed by hypogonadotropic hypogonadism, and we even see that in adolescents. So just be aware that does occur.
And there's another question. What if the patient didn't have any radiation but just chemotherapy? What's the recommendations for this? About hypopituitarism developing later in life.
There is no standard recommendation following chemotherapy alone at this point. Depending on the kind of chemotherapy, there's maybe a risk for infertility and ovarian failure in female. But in terms of hypothalamic-pituitary dysfunction, there's not adequate, consistent data to suggest that there should be active, ongoing screening. But as I think we need to emphasize, these are guidelines. If your clinical suspicion is that this patient needs to have a certain kind of testing because of the clinical presentation, then you absolutely should do what you think is clinically indicated. But there are not sufficient data to establish standard recommendations in that context.
The question is about a hypothalamic pituitary lesion as opposed to just chemotherapy. Again, data are unclear, but presumably if the tumor is stable or smaller, there's much less likelihood that they are going to develop pituitary hormone deficiencies over time. Clearly, though, lesions can recur. So again, if you have suspicion that there are clinical symptoms or signs, you need to test them.
I wanted to ask the audience a question because this patient got proton beam radiation therapy. And I'm very impressed at the confusion that exists about the pros and cons of proton beam radiation therapy. So this patient got 3,600 whole brain protons. How many people in the audience think that the hypothalamic-pituitary dose will be different if you give 3,600 protons to the whole brain versus 3,600 photons to the whole brain. Yeah. I'm glad to see only a minority. Protons, when you radiate an organ with protons, they get exactly the same dose to that organ as they would with photons. Protons spare neighboring tissues. So if you radiate the posterior fossa with protons, you get a smaller dose to the hypothalamus, which is anterior. But when you radiate the whole brain with protons, the dose to every organ in the brain is the same. So it doesn't spare the target organ, it spares neighboring tissue. And I think that is a common misunderstanding. So.
Yes, and there was another question from the audience. As the radiation treatments may change or have changed from previous older studies, how does the recommendation deal with that? So changing oncological protocols.
Well, it's based on the dose to the endocrine organ. So you need to know what the dose is to the endocrine organ. So if you're using smaller radiation fields or lesser doses, then the target organ is going to get a lower dose. So the guidelines won't change, but the risk for an individual patient will be lower because they're getting less radiation. But it wouldn't affect the recommendations because theirs are based on the dose received by the hypothalamus and pituitary, not the dose administered. Yes. And that's really a key difference.
Yeah, so Dr. Antal, looking at these graphs, another question from the audience is, so how long do we keep on screening?
Right. Right. So really, we don't have a cutoff for when we would stop. In the guidelines, we say sort of indefinitely, annually, for good. I think instinctively we begin to wonder if somebody's levels are normal over time, how long they will be normal. But I think this data guides us to remember that that's not, we can't hang our hats on that because these patients could develop this at any time along the way. So we don't really have a time at which we recommend stopping.
Yes.
But it's really important to highlight that this is an area of research that we really do not know when it ceases to be a risk. So I think this is also important to know that it's an area that we are looking at as we continue to follow these patients long term and have also discussions amongst different groups monitoring such patients.
Great. So
right. And we're recommending annual screening, which again has never been subjected to any kind of comparison testing. We don't know if screening yearly is cost effective, if you could get away with screening some patients every 2 to 5 years versus every year, or as they get older, maybe you want to narrow the screening. None of those things have ever been studied or tested, so the guideline recommendation is annual lifetime screening, but that's in the face of inadequate data to support the optimal both timing and frequency.
Thank you so much. So to get back to the case, so the young male of 28 years old, almost 20 years after his treatment, still using levothyroxine and hydrocortisone, has normal free T4 levels with lower TSH levels, fitting the diagnosis of central hypothyroidism. His testosterone in the morning, 9 a.m. is low, with LH and FSH detectable but also low, and IGF-1 clearly also too low. So in conclusion, this young male has a pan-hypopituitarism. So now the question is the recommendation for growth hormone treatment in childhood cancer survivor adults different than for non-childhood cancer survivor adults? Oh, sorry, Dr. Cematilli?
So in the guidelines, we don't make a distinction. We don't recommend anything different from what's recommended in the general non-cancer survivor population. So it's really no different as to what would indicate treating with growth hormone. It is, however, important to remind the audience that this is a population with multiple comorbid conditions, and that the true risk-benefit ratio of growth hormone replacement, especially that it becomes sort of open-ended in adults, really needs to be discussed with every individual. And it's an active area of research where we don't know how many of these symptoms could really be overcome with growth hormone replacement, and whether other interventions could help as well. So I would see this still as an area of active research.
Okay, thank you. So the recommendations relevant to this case is that we do recommend lifelong periodic clinical assessment for growth hormone deficiency in survivors treated for tumors in this region and those exposed to radiation to the hypothalamic-pituitary region. And that when a child has had growth hormone treatment, that it is retested reaching the adult age. Also, it's recommended to lifelong screen for TSH deficiency, ACTH deficiency, and FSH deficiency. So we have 5 more minutes. Maybe if there's any questions from the audience, and also I have more questions on the app. Let me see. Are there any recommendations for evaluation of cancer survivors now on the new treatment, such as the tyrokinase inhibitors or immune modulators? There's, of course, the new drugs now with the checkpoint inhibitors giving hypophysitis.
So this is a very good question, because this is an area of immense challenge to us taking care of children on active cancer therapy. A lot of new therapies, so-called targeted chemotherapies in particular, cause disruptions to the endocrine system. Tyrosine kinase inhibitors are known to be clearly associated with problems with growth, hypothyroidism, and possible other problems. Immune checkpoint modulators also can cause panhypopituitarism. We don't really have clear set guidelines. Most of patients enrolled on such protocols really have time points for checking on these different outcomes that are embedded in their protocols. But this is, again, an area where we need to get more information and learn more. These were not covered within the scope of this guideline, however, as you don't have enough data.
Except we do make one recommendation, which is that we suggest against using growth hormone therapy in children who are on active tyrosine kinase inhibitor therapy because of lack of data supporting both efficacy and safety. That was the only recommendation that we made in regards to tyrosine kinase inhibitors. But this wasn't. It's such an active, ongoing area that, and it's mostly acute, not long-term issues we're talking about primarily.
But there are also now effects that we're seeing directly on the growth plates, and that needs to be taken into consideration, and not overdiagnosing, for example, growth hormone deficiency if these agents are having direct effects on the growth plates.
Thank you.
So, Miller from Minnesota. My question was related to the fractionation of total body radiation that Dr. Sklar mentioned. Has there been any recognized impact on the spine growth in TBI compared at lower doses compared to the specific spinal radiation and fractionated doses for other treatments?
Yes, there have been a number of papers, but TBI at standard doses and hyperfractionation has a profound effect on spinal growth. And patients who get TBI are unfortunately among those who respond least well to growth hormone therapy. So, and again, the younger they are, the greater the impact on growth.
Thank you.
Yes, please.
Vergara, Buenos Aires. A short question regarding the second patient. It appeared that it came a little bit late to the pediatric endocrinologist because of the bone age. And if we would have seen that patient 2 years before, or we monitor with the oncologist, what would be the follow-up? We couldn't rely on testicular volume, not even growth velocity. It would be a cost-effectiveness to do some test of testosterone with mass spectroscopy. What is the recommendation in those patients?
Dr. Ciameteli, maybe?
So I think really the sequence in this patient was probably unrecognized precocious puberty for a while. So the key element was they're recognizing precocious puberty by, when in doubt, measuring a testosterone level, because we can't really rely on the testicular volume. I personally also look at secondary sexual characteristics, but then again, we see so many of these patients. So scrotal thinning, pubic hair, Other characteristics might be, more suggestive of pubertal development in this population, but definitely and clearly, diagnosing puberty early enough could have helped with a different outcome for this patient, and initiating pubertal suppression at an appropriate age where it could have made a difference.
Yeah, this was actually my patient, and this patient was being seen by an extremely sophisticated group of brain tumor specialists who are very sensitized to these issues. Nonetheless, this patient's early puberty went unrecognized by the treating team, and a little bit that the family didn't follow up a year after treatment as they were recommended. So I think it's unlikely that there is anything one could have done that would have actually allowed the diagnosis to happen earlier. But again, I think it highlights the fact that these are subtle things that are unlikely to be picked up by folks other than ourselves in this setting. And I think that that's what we need to strive for, is to get access to these patients as early as possible.
As an endocrinologist, if you're following a patient serially, sometimes seeing a big jump in testicular size, so somebody who has very small testes that are suddenly 3 cc testes within a period of 6 to 12 months, again, scrotal thinning. So it's knowing your physical exam. And it's another point where it's actually helpful to have the same person measuring.
We have one last question. Thank you.
Yes, Steelman from Fort Worth. Would you please expound a little bit more on measurement of sitting height in terms of trying to track patients who have impaired spinal growth? Specifically, if you have any techniques that you're doing, and also what standards you're using.
Okay, so we need more information about the standards of the sitting height, and how do we measure sitting height?
Yeah, well, there's we actually have a real stadiometer that was made in England and shipped to New York, but I don't think they even make them anymore. You can measure sitting. You can easily have somebody build one easily. You can measure from the bottom of a chair. You can have a measuring device. The issue of standards is a huge issue. We actually use the Dutch standards because they're the best, and there's questions as to their relevance to North American standards. I was happy to see that the Brazilians had a poster where they've actually started looking at sitting height over standing height ratio to look for dysmorphic short stature, but they compared their data to the Dutch and found them to be pretty much superimposable. So I use the Dutch sitting height standards, and they have growth sitting height charts, and you plot the patients. And what you see is that the leg length continues to follow the normal curve, and the sitting height flattens out as they get older. It just it just verifies for you what you're clinically suspicious of in these settings. For patients that just get radiation to the spine, who are very short, documenting that that's the etiology of their overall short stature pretty much cuts through the need to do any hormone tests for patients that have no risk factors for hormone therapy. And one of our suggestions in the guidelines is against using growth hormone therapy in non-growth hormone deficient children who are short due to spinal radiation. Those have gotten abdominal, mediastinal radiation, but no cranial radiation. Those patients can be very, very short. And there's really no compelling data to suggest that growth hormone therapy is beneficial. So.
One other follow-up question, if you don't mind. What about the child or the individual who has severe scoliosis? Those are more difficult. Do you use arm span, or are there any other surrogate measures that you use when trying to assess their growth response?
I use arm span in those cases because it can be difficult to just look at sitting height alone.
Okay. So thank you so much. It's 9:30, so we have to end the session. Thank you so much for attending, and if there's any questions, please approach us. Thank you.